Good morning. My name is Amy Bellman Davis, and I am Executive Director of Unite for Sight. Unite for Sight is a global health nonprofit organization that promotes high-quality care for all. Unite for Sight is committed to excellence in education and has just launched the Global Health Idea Lab, which is a unique new virtual event series that is free and open to the public. Today's virtual panel is entitled Embedding Data and Evidence in Global Health Programs, and we are delighted to welcome our expert panelists, Lisa Hirschhorn, Gary Krebs, Catherine Semra, and David Tovey. Daniel Palazuelos will be moderating this session. Daniel is a global health implementer educator who holds positions at Harvard Medical School, Brigham and Women's Hospital, and Partners in Health. He started his career in global health equity by living and working with community health workers in impoverished communities in Chiapas, Mexico. And these grassroots experiences have deeply influenced his approach to addressing the biggest challenges in global health. Over the last decade, he helped to launch Compañeros en Salud in Mexico, the Financing Alliance for Health, and the Community Health Impact Coalition. Please join me in welcoming our panel.
Thanks so much, Amy. That's a wonderful introduction. And this is a really exciting opportunity to sit in this space, virtual, because of the current circumstances. But I thought it would be really great to first go around and have everyone introduce themselves. So David, why don't you start?
Well, hello, my name is David Tovey. I'm currently working as a senior editorial advisor for three major COVID projects. One is called COVIDend, it's based in Canada, which aims to bring together researchers and evidence users to try and coordinate activities in what we've just been calling the sort of COVID storm of evidence, aiming to reduce inappropriate duplication and research waste. Also a program called COVID Network Meta-Analysis based in Paris, where we're looking to synthesize all the data that's coming through from the randomized trial and produce a network meta-analysis. I'm also working for Evidence Aid, which aims to provide evidence for disaster areas. So for the last 10 years, I was editor-in-chief at Cochrane, the Cochrane Collaboration, which is an international organization which produces and publishes systematic reviews. And so I was responsible for the content we produced over that period, around 800 systematic reviews a year. Prior to that, I worked at the evidence department at BMJ. Before that, I worked as a GP in South London.
Thanks so much.
The family
next,
doctor,
Gary.
sorry.
Thank you. Gary.
Hi, my name is Gary Krebs. I'm a distinguished professor of communication at George Mason University, where I direct the Center for Health and Risk Communication. I've had a very long career as an academic and I've also worked in government, and I do primarily field-based, community-based research to try to address major public health issues that deal with issues of equity and control and access to relevant information. I'm one of the founders of the field of health communication. I've been working in this field for more than 40 years now. I spend a lot of time working with federal agencies and international agencies. The research I'm going to be talking about today is a program I started called Insights, International Studies to Investigate Global Health Information Trends. It's based on a research program that I began when I worked with the National Cancer Institute as the founding chief of the Health Communication and Informatics Research Branch called HINTS, the Health Information National Trends Survey, where we tried to find out where the American public was getting health information, what they knew, what they thought they knew, what they didn't know, what they misunderstood, and where they were getting the information so that we could use that information for directing development of public programs at all levels to reach those people who are misinformed and to help them make good decisions, ostensibly about cancer, but about a wide range of health issues. When I left the National Cancer Institute about 15 years ago to go back to academia, I started doing this work internationally because we saw how powerful it was in the US. And since then, we're now in more than a dozen different countries and many more are coming on. So I'm hopefully we can talk about some of that this afternoon. Thank you.
Thank you. Catherine.
Hi, everybody. I'm Catherine Semra. I'm the director of the Better Birth program at Ariadne Labs, which is a joint health innovation center that sits between Brigham and Women's Hospital and Harvard T.H. Chan School of Public Health. And I'm also an assistant professor in the Department of Medicine and the Division of Global Health Equity at Harvard Medical School. My training is as an epidemiologist. I have a PhD in epidemiology and a master's degree in international health and epidemiology. And my work initially was really focused on HIV, prevention of mother-to-child transmission of HIV, and have kind of spread my scope of work now to focus much more on maternal and newborn health. I am a clinical trialist in that I've implemented large-scale clinical trials that have been trying to improve the quality of care for maternal and newborn health. And I think over the course of my career have transitioned from very much a clinical trial approach to much more of a community-based implementation science approach, looking at how quality of care can be improved. And really excited to talk to everyone today.
Thank you so much. A lot of great stuff to talk about there. And Lisa.
I am professor of medical social sciences at Northwestern Feinberg School of Medicine in Chicago, and wear a couple of other hats as well. I'm senior director for implementation improvement science at Last Mile Health, which is a NGO that is doing work in a number of countries, strengthening community health workers. So able to work with Dan there, as well as adjunct faculty at the University of Global Health Equity in Rwanda. My background, I started off life as a HIV primary care physician, and through that sort of had feet in both sort of research, sort of phase 1, phase 2 clinical trials, quality improvement, and clinical care in the community. And so a lot of the work that I've done since then has really been driven by the recognition of inequity, whether it is of information or knowledge access. For me, it was just going a mile down Columbus Avenue. And since then moved into global health when PEPFAR came in as an opportunity to not just expand access, but also ensure that quality was at the same time. Since then, I actually then worked with Partners in Health, starting their monitoring and evaluation and quality work, and became what I call a little bit more content agnostic. So I do now a lot of work really focusing on implementation research. So how do we actually accelerate the generation of usable knowledge, of effective knowledge, and using that to really improve quality. And so, you know, I think what I'm hoping to really look at and discuss today is how do we actually take the evidence as it emerges, or even evidence that we have to dust off, since there's a lot of evidence-based interventions that we're not actually doing, and what does it actually take to get that into the sort of 3 gaps that I tend to work on, one of which is knowledge to policy, but also then policy to action and action to quality. And how do we not just think about better measures, but the change that's needed in the culture, the change that's needed in the capacity, and would also love to sort of talk about the role of embedded research. So as we build capacity within countries, within partners to address the inequities, not just of care, but also of research that have been, I think, written about quite eloquently in the last couple of years.
Thank you so much. And, you know, I'm really excited about this, and I hope that the people who are tuning in are really excited about this too, because some of you guys I've known, Lisa, we've known each other for almost a decade. Others, Catherine, you know, we share some mentees, and Gary and David, this is our first time to speak, but the work that you guys are doing is so timely for efforts that we've all worked on. So I think this is going to be a fantastic conversation, and we really hope that it is a conversation where we go back and forth and try to dig into some of these questions. So I'll just start off maybe by exploring a little bit this title, Embedding Data and Evidence in Global Health Programs. So global health programs, just to make sure that we're all on the same page, I understand is describing any effort by, say, a government, a non-governmental organization, even private sector entities to improve health with a focus on vulnerable populations and resource-poor contexts. A lot of us work in those areas, and before this, we were talking about all the travel we were able to do before our travel was cut short by COVID. Now, data and evidence, on the other hand, personally, it reminds me a little bit of this term called evidence-based medicine. I myself am a practicing physician, and we often talk about practicing evidence-based medicine, It was defined by David Satchett, I believe, in the 1990s as a conscientious, explicit, and judicious use of current best practice making decisions. Now, in this case, it was for individual patients. We're going to be talking more about larger health programs and policy that then influences how individual patients experience outcomes. But really the operative word here, it's a verb, is embedding. And I think that this asks us to envision data systems that are inextricably linked to how we develop and run global health programs and the ones that we advocate for. So how we get data, how we interpret data, how we use data, and then how does that become a continuous positive cycle? I think that that's a very timely question. I think it's accelerated by what we're experiencing right now. And you guys are really the cutting edge world experts on this. So I have goosebumps. Let's start first by setting the stakes a little bit. Let's talk about what happens when we don't follow the evidence to run programs. You all have been working in this for a very long time, and I'm sure have a lot to share on this. Can you give some of your, perhaps a story or an experience of what went wrong when decisions were not, quote unquote, evidence-based?
I guess this is Lisa. I could start, having come from the HIV era before there were treatment and some of the sort of parallels that we're seeing now where sometimes situations where the evidence is only now emerging sometimes will force people to grab onto something and designate it as evidence. And it becomes more what I call belief-based practice as opposed to evidence-based practice. And we certainly saw that with HIV, where people were making decisions based on remedies for which there were no data, turned out to be ineffective. We saw that also where people made decisions based on economics as opposed to evidence. So in terms of the number of drugs, for example, that people were using, or the drugs that people were actually using once we actually had effective treatment. And each one of them, the cost was very high because it ended up with people who died because of drug resistance, because of ineffective care. So I think that there's evidence in that era when new evidence is sort of emerging. But I think also, we can just look at some of the vaccination practices here in the United States, where it's, again, I'm looking at this from the demand side as opposed to the supply side. So what communities believe, which is not actually based on evidence and actually is based on either anecdotes or on poor evidence. And I think I was sort of really listening with interest about the communication and we tend to think about how do we better educate our providers, how do we better educate our policymakers, but also not missing the important thing of how do we better educate community.
I'm going to jump in at that point because of the communication issues. Early in my career in the 80s, I worked with the National Cancer Institute to evaluate their physician data query online information system. It was a really revolutionary system designed to provide community-based physicians with the latest information about cancer treatment, diagnosis, research to guide the best care. The National Cancer Institute had done some studies that showed that thousands, maybe millions of people were getting substandard cancer care across the United States because community-based physicians didn't know the latest treatments, didn't have the best information, and were using outdated modes of care, and they wanted to get the information out. And so the National Cancer Institute decided they would come up with a repository of information, an online information system that they would provide for free to healthcare providers across the country to guide their care. And they put this together with millions of dollars of taxpayer money, and then found out that very few community-based physicians were actually looking at that information and were using it. And even though they had what they felt was a very robust system, it wasn't working very well. It was a classic breakdown in communication. And I think we see that this kind of problem happens quite often, that there is good information available, but it's not necessarily well distributed and disseminated to the people who need it. And not just healthcare providers, but consumers as well. And so one of the things that I like to do is to figure out Where are those breakdowns in communication, and what can we do to try to communicate relevant information more effectively so people can make the best evidence-based decisions about improving their health? And this happens at multiple levels, at the individual level, on the family level, on the group level, nationally and also internationally.
It kind of makes me think that when we talk about communication of health information and data, you have two sides. You have the people producing the data and then the people hearing the data. And sometimes a big part of that is also trust and the sources and whether or not we speak in ways that people understand. So like the vaccination question, we know the story is well told about how it was fake data, timely, people are calling things fake news. And that sort of launched a movement that we really haven't effectively addressed, largely because there remains this fundamental different, perhaps worldview, questions about societal position and trust. We're seeing similar questions arise with COVID. We saw this quite viscerally during Ebola. So I'd love to hear some more stories, but perhaps we can also embed in some of this question around data quality. We can get to trust in a little bit because that gets deeper into societal questions. But data, let's talk about data quality. You know, we know as researchers that there's, you have some preliminary learnings, and then you have many different styles of conducting studies. And then a lot of people say it's not until you have a randomized control trial that you have truth. I've always enjoyed that the people who advocate for randomization and for rigorous trials, they call them randomistas, coming from my neck of the woods in Latin America, the randomista. So these people who are randomistas can be quite militant about the need to do this and say everything else is wrong. But I wondered if you guys could talk a little bit about data quality. And of course, I'm looking at you, Catherine, because yours is probably one of the best and I think most important examples of rigorous trials and how that changed things.
Thanks, Dan. I mean, I was thinking about this question a little bit, and I would say I am a randomista in that I believe in the value of randomized control trials, and I believe that they offer us evidence in ways that are very important to understand. And at the same time, it is important to have different strategies of data collection that address different needs of information and the types of information required. So I helped lead the Better Birth Trial, which is one of the largest maternal newborn health, public health trials conducted that was really trying to evaluate the impact of the WHO Safe Childbirth Checklist, along with a peer coaching model at the frontline facilities. And this was work done in Uttar Pradesh in collaboration with Community Empowerment Lab, Population Services International, and I had the fortunate opportunity to work with Lisa on this study. And we followed over 157,000 mother-infant pairs. And in order to evaluate this large-scale intervention, the study design was a randomized control trial and offered us more than 204 million data points across the study that we collected of qualitative and quantitative information that really offered us key insights into what worked well in the intervention and then what didn't. Because at the end of the day, we saw improvement in the quality of care as measured by adherence of basic practices, but it didn't have an impact on mortality. And so being able to unpack the 204 million data points over the past couple of years has really given us insight into not just what happened, but why it happened. And I think that's where the data quality and understanding that it's not just about collecting the quantitative data, but also really looking at the qualitative piece to understand the why is really a critical point. I thought about, one of the messages I want to get across in this session is that data is not an add-on. It needs to be part and parcel of engagement and programs and how we think about learning on the program implementation process so that we know if something's working or not working. And the way that we get that is data. There are different kinds of data that we can use, and the data quality is really an important piece of it. But I think it's important not to just dismiss an intervention or implementation science because it's not an RCT. that has its place, but also these different intervention designs and these new methods and implementation science have really opened our eyes, I think, globally to how can we learn effectively, quickly, and make changes to programs for success.
I just wanted to underline that, because I completely agree with everything you just said. So, I probably also am a randomista. I was a family doctor in the 1990s in London. And as part of my job, I doled out hormone replacement treatment as per the guidelines at the time, on the basis of observational data that seemed to show it was cardioprotective. I listened to the specialists telling me that really people just needed, women just needed a hysterectomy and estrogen treatment for the rest of their life, about the age of 40. These were mostly men. I doled out antidepressants because we were told constantly we weren't finding enough people with depression. So we wildly overused antidepressants. So, you know, the randomized trials paid for at least one of those. So I think they absolutely have a place. But I do think there's also, you're absolutely correct to say that there are sometimes perception is given out by some of the sort of evidence community members, the members of the evidence community, that randomized trials are everything. And indeed quantitative evidence is everything. And it seems to me one of the insights of the last 10, 15 years, maybe 20 years, I don't know, is that we should be more inclusive, and that, you know, different questions have different, need to be studied in different ways. And this idea that was one thing that's always best is probably falling by the wayside, and about time too, I would say.
And I think one of the other areas that I think there's been a lot growing interest and recognition is that, you know, for the things that a randomized controlled trial has said, you know, this actually does work, you know, certain kinds of vaccinations, certain kinds of ways of treating malaria, you know, the innovation that's needed is in delivery. And so another opportunity potentially for randomized trials is actually not for the evidence-based intervention, but the innovation of delivery. So two different deliveries, you know, is it better to do community-based outreach, or is it better to have trained community health workers to individually deliver vaccines? You know, should we be, as we've all switched to televisits, after, you know, when we were able to come back in, is it equally effective to continue televisits, or do we want to actually do something else? So I think, you know, thinking a little bit beyond just what traditionally people think of, which is, you know, the actual pill, vaccine, whatever it is, that it's actually also the strategies. And those are ones which can be very, very contextually dependent. So as you say, there may be no right answer. So what works in urban may not work in rural. But I think that for me is kind of the next phase. Atul Gawande, who I worked for, and Catherine at the same time when he was at Ariadne Labs, used to say that the last century was all about the discovery of medical, you know, sort of medical discoveries, how to treat cancer, vaccines. And this century has to be, how do we get it to everyone everywhere? And that has really sort of stuck with me.
One of the other pieces, sorry, Gary.
I was going to say, I'm one person who's not a randomista, so I thought maybe it'd be nice to have a contrary perspective. I don't have anything against randomized trials, but I rarely do that. I tend to be much more interested in formative research, especially getting to know the unique characteristics of different cultures and contexts, and understanding the perspective about health from the voice of the consumer and the perspective of the people who deliver care. I find that we often jump to intervention without really not understanding very well the unique dynamics that exist, especially in different countries. And I think there's a terrible hubris that health experts have of thinking they understand better than anybody else how to solve problems in different cultures where they really have no right to make those decisions because they're not part of that culture. They don't understand it. And so I've really focused a lot of my work on getting to understand the unique dynamics, typically through multi-methodological research, especially a lot of you know, in-person evaluation, observation, use of qualitative data. I typically use all different methods, including experimental, but I really think that we need to think broadly about designing research methods and approaches that really match the unique questions that we're asking and give us the data that we need to make the best types of strategies and programs and policies over time. But I love the idea that came up about data being a incredibly important and a necessary piece to doing that. And I think it has to be part of everything we do throughout the whole cycle. But I think we need to be very creative about designing our research in ways that will provide us with the very best data.
David, you're going to say something?
No, I mean, I agree with everything that everything that was just said. I think that, one of the things I was going to say was that there are two things. One is that it seems to me there are two worlds. They're not just the worlds of the evidence producer and the evidence user, but there's also the world of evidence and there's the world of data. And clearly they have overlap, evidence based on data. But with the sort of growth of diverse and big data, there seems to me a whole community of researchers looking at the effects of interventions through looking at vast studies of administrative type data. And one of the things I think is unfortunate is that those two communities actually, it seems to me, I'm sure there are exceptions, interact rather infrequently. Mm. And so for the person in the position of trying to use evidence, it must be really difficult because you have one bunch of folk who use a specific set of methods and come up with something, and then another bunch of folk who use really quite different methods and think about things very differently. And at some stage, I think those two communities do have to sort of try and find some ways of mutual understanding and perhaps some cooperation.
Mm-hmm. Yeah, I think that one of the things I've seen shift really recently, but even in this era of COVID, is watching the scientific communications piece and how do we communicate health data and that research that's happening, or the experience of care. And it's not just about like one infographic type, but it's about how do you share information from either huge AI approaches and what you're learning from large data, like just looking at the growth of the COVID trackers and the information that's out there and the maps and but how do you synthesize it in a way that makes sense and people feel like they can engage with, that they have it goes back to that point of trust and data quality that we were talking about, Dan, about how do we think about all those pieces coming together. And again, that science communications piece, which wasn't part of my training, certainly wish that it was, because I think that it makes a big difference in how you're able to relate to several stakeholders, not just the research community alone. That's a really important trend that I'm seeing now.
Yeah, a couple of things come to mind. I don't know if you know her. Shreya Kangovi is a fantastic physician and community health expert in Penn, who runs the Penn CHW Center for CHWs. And they do a lot of randomized controlled trials for their interventions. And as such, a lot of people look at their work as a very important model because it's proven, so to speak. And she describes how, nonetheless, there is an active agent. If we think of their implementation, like you were saying, Lisa, their implementation program as studying it as the way we would a pill or injection, that there is an active ingredient. And she sees that as compassion, that they do this fantastic job of finding, selecting, and then embedding these incredible natural caregivers into the health system. And then when other groups try to create community health worker programs, they just grab random people, don't pay them, and say, oh, look, it doesn't work, surprise. That was a wrong trial. But, sometimes we have to be careful, and randomized controlled trials can help us really zoom in on what are the active ingredients. It also reminds me, and perhaps this is a way to get to the next sort of set of ideas that you guys are describing, between this rift between data producers and data users. So Camden Coalition, started by Jeff Brenner in New Jersey to help lower costs and address vulnerability. Tul Gawande, who we've brought up here already, as we all know, wrote this very famous article in the New Yorker called The Hotspotters. And it was very exciting. And in our social med class, in fact, at Harvard, we used it for years as a great example of a social medicine intervention. And the tool loves it, so therefore it must be great. And he spoke about it so convincingly. And it's a good read too, right? So Jeff Brenner, though, did almost the unthinkable. He allowed this program that was getting him great fanfare to undergo a randomized controlled trial. And it was published in the New England Journal of Medicine in January, and a bit of a splash for people who care about vulnerable populations because it was a null trial. It didn't actually reduce admissions and costs. Admissions and costs were going down, but both in the control group and the intervention group. And then Atul had a tweetorial where he sent out a bunch of tweets, because of course people were hammering him with, how dare you, you know, never read the comments in the YouTube or tweets and stuff. It's bad for your health. But saying essentially, you know, how dare you promote something that's unproven, right? And his point was, listen, I applaud them for going towards finding greater evidence. At the same time, I think what we're seeing is that these types of interventions do work for older people because they have social supports. You know, they have, in the United States context at least, they have Medicare, they have housing programs, they have transportation programs, food programs, Meals on Wheels. For the poor, sick in the United States that are young, often with addiction problems or just other general downstream effects of years of racism, structural violence, those programs simply don't exist. The social safety net has been torn apart. And so we said, you know, that's an important lesson. Now, anyone from those communities would tell you, yeah, I already knew that. Like, that's my life. Welcome to America. Have you actually been in Camden for a little while? You know, speaking a little bit to your points, Gary, about the context and the culture. So all that fanfare back and forth, all these high level journals and articles and conversation at Harvard and beyond to get to something that we could have known from, you know, the best hip hop albums. So this rift, data producers tend to be academicians, people like us, tend to be wealthy, tend to be white. Data users, policymakers, same thing, also tend to be wealthy, tend to be white. What do we do with this rift? How do we actually stay efficacious? And how do we produce data that then is best positioned to make a real world change?
So Dan, before we go down that incredibly important conversation, I just want to go back to the Camden thing, because I think that the challenge is it's how we think about data. And so randomized controlled trials, you try to make variability go away, right? You control for it, you know, you maybe match people, et cetera, et cetera. Whereas, you know, more sort of practice-based research and a lot of implementation research embraces the contextual factors. And one of the things that we found is, you know, you can sort of do three things with contextual factors about things of, you know, people having homelessness or with or without support or other things. And the first is you can actually address it. So you sort of say, this is going to work and this has been done. We need to actually get people to housing or things like that. Sometimes you can, sometimes you can't. The second is you need to adapt your strategies. So if, for example, part of your strategy was an assumption that there was a social support system in place, and maybe that would work for some people, but not for others, you need to adapt your strategy. And there's smart trials, ways that you can actually adapt that during a trial. And the third thing is you just need to acknowledge it and say, this is unlikely yet at this point to work for this group of people. Mm-hmm. And so I think the problem is that people sort of view these things as kind of yes, no. And for me, the variability is what helps it. And if you didn't do the due diligence of going to Camden and talking to people in advance, at least sort of have the humility to go back and say, help me understand, you know, why this did or didn't work. I think, you know, what you bring up is, you know, this whole field of sort of, you know, community participatory research, but also in stakeholder engagement. And there's some models that we use now in implementation research, one particular called EPIS, which actually starts with a whole exploration and preparation before you dive in and actually do something. And really being kind of rigorous about how we go about doing that, and, you know, brings in a lot of methodologies from areas in which I was certainly never trained and have had to sort of slowly learn or have somebody else help me figure out, you know, what are the things within the organization you're trying to change in the community, who do you need to talk to, and then the people planning for consumption from the very beginning. And I had one experience where I was on this Lancet Commission for Quality, and we had a politician, a policymaker, and researchers, more researchers than the others. And they said, look, you know, the politician goes, I need like one sentence, like, what do I need to do and why? And the policymaker says, I need like one page, like, give me a little bit more information. And the researcher is like, I want the whole peer-reviewed manuscript and things. So I think the other thing is really learning from people, you know, like Gary, others, of how do we actually think about what's the evidence people need? What's the timeliness of this? because, you know, I can do an RCT that takes 5 years, and some settings in which I work, they'll look at me and say, like, that's useless. That could be the best data evidence in the world. It's useless because it's 5 years from now. So I think planning ahead and figuring out who you need to talk to, engage, I think for me is, and I'm sadly have learned from many bad choices I've made in terms of how not to do that, to try to figure out how to do it well.
I think the issue is that healthcare is a multi-level issue, and researchers tend to look at the highest level. We look at it kind of at the policy level, and we don't really look at it at the local level very well. And I think if we miss that out, no matter how good the policies are, no matter how good the information is, no matter how good the medication is, if it doesn't really reach people at the most local level and they don't adopt the information, they don't use it, it's not going to be very effective. And so we need to really go through the entire hierarchy to make sure that the programs and the interventions work, but especially at that local level, because that many times is where the rubber hits the road.
Mm-hmm.
David?
Well, I was just, I just going to agree, really. But, I mean, I suppose I'm a journal editor, and up until, well, quite a long time ago, but I don't know. You know, my idea of how you get a journal article out into the public was that you publish it. Mm. And if it's a particularly interesting article, you do a press release. Mm-hmm. And slightly, and then, you know, Cochrane is a community that produces the reviews. But still, for many years, it sort of thought that was the model. That's how you get the message out. You publish the thing, and off it goes, and somebody picks it up or they don't. And about 5 or 6 years ago, we developed a sort of knowledge translation framework, which is based on people like on this call who know about implementation science, who know about knowledge translation. And you know, the sort of green light for me was understanding that, you know, really it just had to be at the beginning of the process. It had to be throughout the process, and engagement and understanding, working with people, the decision makers, understanding how they'd like the data served up, what the questions they think are important are, maybe involving them in co-production of the review that we were producing. And so, you know, in many ways, I think I'm not particularly unusual as a journal editor. I think there has to be a transition. It probably is also true for guideline makers, by the way, that there needs to be a much better and through the process interaction with the end user, rather than something you just dole out and hope somebody will pick up at the end of it.
Yeah, and you know, it brings to mind a question of what drives the people who produce data to produce data. You know, what are some of the structural issues around our motivations, and then how are those related to, you know, the way that data is consumed? So, you know, as myself, an academician in an academic medical center, I know that a lot of times the metric is publication. And we started off this conversation by talking about how during the time of COVID, we've had almost a COVID cacophony, you know, so many publications coming out. And I know that a lot of those folks, if they're in academic centers, they're getting points. You know, the publishing something actually gets you currency that you can convert to wealth in your own life, namely academic promotion. And academic promotion from, at least at Harvard, instructor, assistant professor, associate professor, full professor, it confers greater earning potential, potentially a lot of prestige, ability to get access to more grants and more wealth and sort of prestige. So at the same time, making sure that your research is understood by policymakers, especially, for example, in contexts where the public sector has been torn apart by policies of neoliberalism and other far-right ideologies, there is that risk then. You know, we at most academic centers and groups that produce data, we're not rewarded for going to Capitol Hill and talking to policymakers and making sure that they understand what we're talking about and making sure that our data translates to something that affects patients' lives. So what do we do about that? What is that fundamentally broken, or have you seen in your own lives ways to get around that?
You really bring up a great point, Dan. I think that the academic system has been skewed towards the development and publication of new data and knowledge without really a focus on implementation. There's not a lot of reward in implementation. There's not a lot of time available. People are really busy seeking out the next grant, trying to gather the data, get it published, and then they're running on to the next project. But I think we need to build in some infrastructure to enable people to actually use the data. So we generate a tremendous amount of data. Most of those data that we collect are not really being well utilized because the implementation is a bear. It takes a lot of time. It takes a lot of effort. It's messy as hell. It's complicated, and we don't really have the time for that. So I think for me, the way that I've tried to overcome that is by trying to build community-based partnerships and work with people who are actually in the implementation business, who are delivering care, including people living in different communities. But we're really not well suited for that. And the academics fear the people in the community because they're so different. But the theory of weak ties says those people who are different have the most information for us. That if we break through those differences and reach out to those weak ties, we learn more. And so one of the things we need to do is to train academics to be able to go beyond the academy and to connect with people who are policymakers, who are implementation people, who live in communities, to work with them and to become their partners. I found that I've learned so much by connecting with people in those communities I would have never known. But I think it's a set of skills and that have to be learned and nurtured for us to be effective with our data.
Other
Maybe
thoughts?
we need a different impact factor.
Yeah, I mean, the personal example for me is really, yes, the main trial was published in the New England Journal of Medicine, and that reached a certain community of researchers. But actually the report, the Better Birth Report, which actually encompassed findings of a wide variety of research investigations and also interviews and questions, that was written in a much more user-friendly manner and good, had the ability to have a graphic designer help us make it beautiful and useful and readable, is actually reached a wider community of the world. And to me, that is the metric that mattered most, is that it was sharing how did this intervention work or not, and what do we actually do about it going forward. And so where I think we do have the opportunity to make change in academia is pushing from within about these are the metrics that matter, that it's not just about the publication of one article or another, but there are other ways, there are other metrics, as Lisa just said. We need a new impact metric that is not based on published in a peer-reviewed journal, but is based on people that we're reaching, partnerships. And I think to Gary's point about these long-term, long-withstanding partnerships with implementation partners and implementation research teams that are based in communities where we have the fortunate opportunity to work, really is what creates the long-term sustainability of this approach, as opposed to focusing on the metric that is valued by the promotions committee alone.
Do you have any thoughts about what other, and the impact factor is, for the folks that haven't heard that term before, it's when a journal has a generates citations of their and downloads of their articles. So some of the highest impact journals, things like the New England Journal of Medicine, Lancet, BMJ, they have published articles that then people look to and send out, partially because they're often really good studies, but also because they're very selective, knowing that they're going to publish stuff that's going to sort of get a lot of attention. But what would that other impact factor look like? Would it be number of tweets retweeted? Would it be, that makes our current executive branch full professor. And I don't know if that would be deserved. What is number of policies that go into practice, number of people saved?
I think those connections around the network, the connections to stakeholders that go beyond academia. I think the point around at Ariadne, we've been trying to think about this lives saved assessment. So how many people are you engaging with? How many are you partnering with? And I think for individual researchers or implementation scientists and researchers, how do we think about the networks that we create? How are we creating actually true partnerships, not things that are like, you know, parachute science, but really a long-term, long-standing approach that's about a collaboration that actually is creating something sustainable. So that metric, I'm not sure that it's tweets per se, but I do think that there are some metrics around partnerships, engagement strategies, and key stakeholders, again, beyond the peer-reviewed publication, but I'd love to hear the others' ideas around metrics.
I think if we track what happens with the research, who uses it, has it developed into policies, have there been programs that have been implemented, who are using those programs? I recommend that when we do tenure and promotion review, or even evaluation of research grants, we look to see whether or not the research has resulted in anything tangible, reducing pain and suffering, saving lives, new policies and programs. What has it done? I fear that much of what we've funded and research that's been conducted and published have ended up only in paper and not really into practice. And so we need to actually follow it along the way, not just for evaluation, but also in terms of the work we do. In communication, there's a concept called exposure. So, you know, first of all, I love the Cochrane reports. As an academic, I use them all the time. But I wonder how much exposure the Cochrane reports get into different rural communities in different countries, for example. Who are they going to understand that? Are they interested in looking at, do they have the patience? Do they have the skills? So I think the translation of what the data means for those publications, the synthesis that we talked about before, is really critical. And we need to give value to that translation and synthesis. We need to thank people for doing that work and reward them for it. But it's not really part of the reward structure right now.
In the UK, academic research is graded on the basis of impact rather than impact factor. Now, it's very easy to say that because it's actually quite difficult, as everybody said, to measure. You know, should it be tweets? I think not. But and you know, there are some great examples. I remember a Cochrane researcher who actually did a big trial and then followed it up with a review and looking at tranexamic for acid for losing blood on the battlefield. And he actually went to the head of the British Army and said, this reduces mortality on the battlefield by 20% or something. And that then changed the approach taken by the British Army, but a bunch of other armies across the world in terms of treating battlefield casualties. And so there are sort of examples, but of course that's the sort of tip of the iceberg. And sometimes very good research is simply confirming something we thought we already knew. And that's still quite important. And how you measure impact on those studies that aren't sort of massively groundbreaking, I think is very difficult. And I'm not sure anyone's really cracked it.
One of the theories I use a lot is called the diffusion of innovation theory. It was developed by Ed Rogers, who's a friend and mentor to me. And I think it's a really interesting theory because it tracks how new ideas are accepted in communities, how things change. You know, things change all the time, but it's usually not very well directed. And many of the changes are haphazard and bad for health. How do we direct change so that it actually promotes health? And typically the way that is through social networks, through connections we have with other people, through the people that we know and we trust and we listen to. And so as implementation scientists, we need to figure out who are those tipping point people who are connected to the communities that we want to do things, and how do we get the information to them, and how do we help them with that implementation piece? How do we disseminate and diffuse information through social networks?
In one of my,
one of the other things, though, that I really don't want to miss is the idea of capacity building, because so far this is really about sort of what does academia do. And for me, the success is that at some point I'm no longer needed because it's embedded, this ability to do the research, to produce the evidence, whether it's, initial evidence or whether it's actually sort of replication to understand adaptation, that it's really being led by people in the areas that need this knowledge the most. And whether it's sort of developing true community-based researchers, whether it's people that are embedded in government. And I think, there's been some recognition recently by funders to actually be able to support that, because usually it was something you kind of did on the side, like, late at night, and was certainly never anything within the grant. So I think, part of this has to be the donors and the funders also recognizing what they need to invest in. And Catherine knows, the ability to convince somebody to invest in a couple of years of preparation and adaptation before you dive into a big trial was not something that was very accepted a number of years ago, and I think increasingly is so. So I think there's a number of people that we need to convince about how to support this. We need to get governments and policymakers to really value that, and then sort of see whether, if you have that, and I think there's sort of growing evidence, that the ability to uptake the evidence when it's generated within the community, within the country that it wants, that actually needs to have it, that I think that's at least one step sort of forward. Recognizing there's still a lot more that needs to be done. And as people have heard me talk before, Semmelweis has always been one of my absolute heroes, who's the guy who figured out you need to wash your hands like over 200 years ago. And we still, surprise, surprise, people should wash their hands with COVID. And there's all kinds of very interesting lessons about what he did wrong in terms of not communicating, not engaging with the doctors. He was thrown out of the hospital. He ended up dying in an insane asylum of sepsis. And so there's a lot of lessons that we keep on repeating about how not to do the next step on good research.
If at minimum I don't die in an insane asylum due to sepsis, then that a positive metric. But David, you're going to say something?
No.
Okay. So, for the last couple of minutes that we have left, I think that the people who call into these wonderful sessions are really thinking about their own careers and are thinking about where are they going to go next. They're hearing us say academia is this and this is what should happen, but they have a very practical choice. What am I going to do tomorrow? Or if perhaps they already have their small NGO somewhere, or they are part of another NGO that's not doing what we're describing. What advice, maybe we can go around as a final hurrah, just what advice would you give them? And then specifically with the focus on, if you have the very practical question of applying for a grant and then creating a budget to then allocate a certain amount to monitoring and evaluation systems versus policy engagement versus community translation, whatever it might be, what are some of the, succinctly of course, what are some of the sort of the main lessons that you would want people to walk away from this session with? Maybe we'll go through the same order we did before. We'll start with David, Gary, Catherine, Lisa.
So, I think thinking of giving advice to people on this call, it's very difficult to do that. But I think if I look back at my career, I would say that I wish I'd been a lot more skeptical. So be skeptical, and don't assume that something that sounds like a good idea is a good idea just because it sounds like a good idea. There's lots of examples of things that sound like a fantastic idea that turned out not to be so fantastic after all. And so I guess in terms of thinking about your next grant, really think about what's going to have impact. And in order to do that, you may have to talk to people who it may impact on, not just bring it out of your own head from your own background. So, thinking really hard about how to change the world. And as part of the evidence-based movement community was really about challenging authority, challenging, not being so deferential to expertise, but really wanting to follow the science. So those would be my short bullet point pieces of advice, I guess.
Gary?
Yeah, I love your advice about, trying to make sure you're addressing important issues. And that's what I tell my graduate students and my people I mentor, is to identify what are the health issues that really matter to you. What do you care about? What is important in your family, in your community, and really focus on that. One of the things I wish that I had learned early on was that I didn't really know it all. I thought I was so smart. I thought I was an expert. I had a degree. I knew how to do research. I could answer any problem. And then I learned through the School of Hard Knocks that I didn't know it all, that I knew actually very little. But I did have some knowledge that would help. And so I think we need to figure out who are the people that we need to partner with and work with to really make things happen, and then really do that work together. You can't do very much all by yourself, but with other people you can get a lot done. And find out what kinds of partnerships are needed to actually make things work. And often there are people who are very different from you, from the community, who have different knowledge, different backgrounds, different jobs, but will complement you and allow you to reach more. And I spent a lot of time working as an advisor rather than the person who runs it all. And over time, many of the projects that I start are owned and run by other people, usually people on the ground in communities, and they become more and more central. And I provide advice rather than thinking I know it all. I think that's a good lesson for everybody who wants to do work that will make a difference.
Wonderful. Humility. Catherine.
Yeah, I can really agree with David and Gary and what they've brought to the table. And I think part of it is really about doing the work, taking the time to engage in partnerships, in true collaborations, understand the history in the place that you're working, especially around the content area that you're focused on, because going in and repeating the same idea over and over again is not helpful to anybody. And the experts live in those communities and that you're partnering with. So I think doing the work to create true long-term partnerships is one critical piece. For the person that is writing the grant and trying to think about what the next iteration looks like, I really think it's about data is an essential part of your program planning and your drafting of your theory of change and your thinking about your implementation and impact approach. Because in the past, there have been line items where it's been like, oh, 10% of your budget should be spent on monitoring and evaluation. I'm very skeptical about saying it's a certain percentage. I think different levels of funding and need are required for different kinds of research trials or monitoring and evaluation work and things like that. But I do think it's really important to include it as part of your approach and budget strategy, and thinking about what are you really trying to answer. It's very tempting to say, oh, wouldn't it be nice to know? You cannot collect data on everything. It's not possible. So really focusing on what is your intervention, implementation, what is your question that you're trying to answer, and how are you going to use that data to its fullest potential to meet the needs of the stakeholders that you have. And then finally, just one extra thing is, if you're in an academic setting where you are getting training in a PhD or an MD or things like that, you likely do not have a management course or a course on how to teach. And so I wish in my academic process and career trajectory, I had taken more courses around management, because I do think as partnerships form and evolve, it's something to really think about. And so having some of those skills as opposed to just the technical skills on EPI would have been really helpful, and something I've learned through the process, but would love to have had a little more grounding in before engaging.
Thank you so much. And Lisa, you're rounding us out and closing up this session.
Great. So I think, obviously just to build on rather than repeat what everybody else has said, which I completely agree with. I think some of the things that I've learned is to stay curious and to be willing to learn from other disciplines, whether it's management, whether it's anthropology, whether it's business, because, we get trained in our disciplines and we have to think outside of that. I think you have to stay relevant. So listening to what's needed, listening what the problem is. I find people who have great solutions and they're looking for a problem. You should listen to what's the problem and then co-develop what those solutions are be. And again, just this concept of we should be always building capacity. We should be mentoring, whether it's junior people within our own circle, whether it's within our partners, so that ultimately you actually can mentor your way out of business. And that is sort of one of the goals that I've always had, which is, to be able to be that I'm no longer needed to be able to help design, and therefore I become more of an amplification for the work that other people are doing. And I think it's an investment, but it is, I think, one of the most critical investments that we can do to continue to sort of evolve how people know how to use data properly, because just because it's evidence-based doesn't necessarily be using the evidence in the right way, and really sort of continue to figure out how to get everything we know that's effective into practice.
Well, thank you so much, everybody. Thank you, everyone, for calling in to this call on Facebook. Stay engaged, stay curious, stay humble. Those are real important words to live by, and I think made all the more relevant with what we're experiencing now in this global pandemic and in our common humanity. So thank you so much, and bye-bye.